Hello, this is Matt Hartman from Pittsburgh, PA. I'm joined by Davin Evanson from Drexel, and we are going to be talking about pediatric issues. I love peds. I almost became a pediatrician. I chose radiology, and I almost chose pediatric radiology. I loved it so much, but eventually did chose on abdominal imaging, but still do a little bit of pediatric imaging in my practice. Again, this can all be found on the ACR Building Block site. I encourage you to get a membership. It's free, and then you can download all these tremendous resources. Here's the QR code for that. And here's some of the material we have for the future pediatrician: anatomy, some intro to imaging, radiation, MR safety, what to order, how to read a chest x-ray, recognizing child abuse, and then my RadPath channel, tons of great stuff, which you can look at if you want to. Here's the RadPath channel, and we also have Anki flashcards for the regular course as well as for the RadPath if you like Anki cards. Make your own cards. Again, I'm a body imager, but I love RadPath and I love pediatric radiology. So this is to prepare the future pediatric intern or a med student doing your pediatric clerkship. And again, I encourage you to download the entire presentation. It's over 190 slides. I'm going to try to get this between 25 to 30 minutes. I'm going to take a little pause on each slide, but there's no way I can read each of them. And if you like it, you can pause, take your time with that slide, or even better, download it yourself. But I want to show you what we have. So the outline, we'll start with some basic vocab, go over some concepts, throw in some Hartman pearls, and then a ton of cases. Davin will go over one or two of those, but there are even more cases on there, interactive, you can do on your own. Again, this is from the building blocks, so there's some basic ones. If this is the first time doing it, I encourage you to look at some of those basic building blocks presentations, especially about basic topics and how to read a chest x-ray. Okay, so here we go, covering a lot. So let's start with some vocab. So the cardiothoracic ratio. This is very important with peds when you take into account the thymus can look like a mediastinal mass, extra big heart, but you have to be aware of that. And the lateral chest x-ray helps with that. Air bronchograms. Lung nodule less than 3 centimeters. That are seen on the CT. Then lung mass greater than 3 centimeters. And yes, we will see some of these in peds, but much more common in the adults. Atelectasis is volume loss. Again, this is something we cover in the intro chest x-ray. 4 different types of atelectasis. Felson's does a great job if you have access to that book. Pleural effusions with the meniscus. Silhouette sign can help you tell what lung segment is affected. Tree and bud. We're getting to springtime, and you see these little tree and bud opacities that tells you infectious or inflammatory. Usually. Ground glass, somewhere between normal lung and a full alveolar consolidation, just a little bit gray. We'll talk about bowel distension. Everything's just a little bit expanded versus dilation. We'll learn the rule of threes. More than 3 centimeters for the small bowel is abnormal. And you're always worried about obstruction, looking for transition point. As opposed to ileus, can be focal, upper abdomen, or everything, generalized, small and large bowel, usually a post-op patient or someone on narcotics. Small bowel obstruction, it's important to know how the film was taken. This one's upright, and you get the stair step and air fluid levels. Large bowel obstruction. Pneumatosis, so very worried about this in the peds. So air in the wall, you're worried about neck, ischemia. especially in the preemies. Extrav, patient drank some contrast instead of staying in the GI lumen, it goes everywhere. Worried about a leak. They're shown on the CT scan. Fat stranding, so right lower quadrant pain. There's our appendix, looks a little bit dilated. Zoom up. This is the normal fat here, but this is a little bit gray fat. This is what we call fat stranding. Worrisome for appendicitis. Hounsfield units. I'm not going to spend too much time. Hopefully you've done the intro talk about radiology where we go over this in detail, but realize it's a scale of CT density, -1,000 for air to +1,000 for metal/bone. Water's in the middle at 0. And we can use this to our advantage for windowing. If we want to look at the lung detail, soft tissue, or bone detail, just move in the gray scale. Again, we go into much more detail in the other intro videos. Same thing with some of the MR sequences, being able to tell T1 from T2, some of the special sequences. And you can pause the video here, read the slide, or you can just go to the next topic, concepts. So this is something else I'm going to just go through. We talk in much more detail about how to read a chest radiograph, different ways to do it. The Felson's way, the A, B, C, D, E. The approach is going to be shown here, looking at the different compartments. The most important thing is you do it in a systematic way. The first thing you always start with, quality check. Make sure you have the right patient and look at the parameters of penetration, inspiration, and make that assessment. Was it a good study or not? And always start with lines and tubes. And we're going to look at the lungs, look at the airway. Is there any shift, displacement of the airway, the pleura, the hyla, the mediastinum. We talked about the thymus in kids. The diaphragm, looking for free air under the diaphragm. Cardiac, the bones, always looking for child abuse. Well, I'll have a special talk about that at the end, and there's a special module. And then soft tissues. Realize it's important to know how the film was taken, AP versus PA. This is something we talk about in the intro videos, but you will always have some magnification, especially if it's a AP study versus a PA study. Heart's the same size, but the heart appears smaller in the PA radiograph. AP has more magnification. Okay, let's talk about some PED-specific things. Neonatal respiratory distress. These are going to be in our preemies, and remember that they have a deficiency of surfactant. Lungs can't expand as much, and you sort of get these ground glassy reticular densities, and the lung volumes are low in this patient. We do lines and tubes first, as the tube help in the breathing. Transient tachypnea of the newborn. So see this often in babies that were born C-section, didn't get squeezed out. There's a little bit extra fluid in the lungs, looks sort of like CHF. 24 hours later, normal radiograph. So history is helpful there. Neonatal pneumonia, again, airspace opacity, blood, water, cells, or pus. That's something we talk about in the intro videos. Meconium aspiration. Again, hopefully we will have that history of the concern for meconium aspiration at birth. And again, these patchy opacities. And the complications, we're always looking for pneumothorax, pneumomediastinum. Some congenital things we'll talk about. Again, if we're looking at the diaphragm as part of our search pattern, no normal diaphragm there. Instead, we see bowel gas going all the way up. And it can help to see where the feeding tube is going. A couple of pediatric congenital things, something called a CCAN, sort of cystic. We have a spectrum of cystic lung disorders. This is one of them. It's a hamartoma of the lung. And CT, you can see Truth Machine gives us much more detail than the radiograph, but the radiograph gives us some great information. We see the mediastinal shift here. And you know something's going on in the right lung, but with the CT, you better see the cystic lung disease. And that will help our pediatric surgeon know what to do. One of my favorite things, congenital lobar emphysema. I did a report as this as a med student. I thought emphysema was only an adult diagnosis, but this is something we will see in the left upper lobe, right middle lobe, again, a congenital thing where you get hyperexpansion of one of those segments here in the left upper lobe. And look what it's doing to the heart. That's part of our checklist. Airway, heart, mediastinum, it's all shifted the other way. Sequestrations, you can read about this, separate into intralobar or extralobar. And this is one of the reasons I love pediatric radiology, just these really cool differentials. And as a radiologist, you can nail the diagnosis. So always worried about airway. That is one of our first things we're doing as our checklist, looking at chest radiograph. And it could be with kids that put anything in their mouth, so always worried about foreign bodies. Also worried about infectious causes, croup. There is the steeple sign. We're looking at the airway. Epiglottitis. This before the vaccines, this was a deadly diagnosis, still deadly, but I think with the vaccine, much less common, but still something to be very worried about, especially people who aren't vaccinated, typically caused by the H influenza. That can get a sick kid crashing really quickly if the airway is not protected. And they also call this the thumb sign. Okay, retropharyngeal abscess. And we're looking at the spine. Do the ABCs. There's too much soft tissue there, confirmed on the CT. Again, have to be suspicious about this to order the right test. That's the first thing, and then make the diagnosis and then treat it. Foreign bodies. So kids will eat anything. You see the foreign body here. Most of them are not visible on radiographs, but this one is. Enlarged tonsils, adenoids. So pediatric chest, some of the topics that will be covered here: pneumonia, acute chest syndrome, cystic fibrosis, mediastinal mass. So pneumonia, again, something too white or opaque, blood water cells pus. And something unique to the pediatric populations around pneumonia. And we always worry if it doesn't resolve, you worry about something congenital causing a blockage that the pneumonia is not resolving. Acute chest syndrome. So these will be our sickle cell patients, pain, and get an abnormal radiograph. Cystic fibrosis. We have a big population here in Pittsburgh. The X-ray findings, the CT findings. Usually you have the history, but we're looking for the complications: pneumothorax, pulmonary hemorrhage. Mediastinal mass would be scary. That's lymphoma. Every differential, especially for adults, but lymphoma, then the 5 Ts, teratoma, thymoma, someone with the aorta, thyroid, terrible lymphoma. CT is going to be really helpful, telling us solid versus cystic. And again, we don't want to mistake the normal thymus for a mediastinal mass. So cardiac. I did a whole rotation as a med student in peds cardio. Again, I thought I was going to go into pediatrics, but I was just so fascinated with the congenital heart disease and learned so much on that rotation. So things to look at: pulmonary vasculature, cardiac size, and situs. And it's very important to know cyanotic versus acyanotic. It's always sort of the beginning of the branch when you're thinking about pediatric cardiac malformations, having the history. So some common things: tetralogy of Fallot, the boot-shaped heart. You can look up what 4 things make up the tetralogy. Epstein's anomaly, pulmonary atresia, box-shaped heart. Truncus arteriosus, and we're often looking for the right-sided aortic arch. A couple pearls thrown in here. Again, I'm not going to read everything for you. Total anomalous pulmonary venous return. Different subtypes. Always remember the snowman heart. Just love these radiology signs. Transposition. Egg on a string because of the narrowed mediastinum. Again, knowing cyanotic versus acyanotic. Tricuspid atresia. And then our non-cyanotic ones. So a lot of the shunts, so these will have increased vascularity. So that's an important thing to make a note of. And then some obstructive lesions. So left-right shunts present with hyperinflation, hazy lung fields, plus or minus defects. And we're looking to see what chambers are enlarged. That will help us figure out what's going on. And in reality, the kid's going to get a echo anyway, but I think it's helpful to think of some of these things. So our stenoses, the coarct, seen real well on the CT, the figure 3. Kawasaki's can be a scary thing if you ever treat a patient with that. The myocarditis, enlarged heart. Then we worry about the complications, the aneurysms after. Again, echo is going to be so helpful. MRI, for especially if you're worried about a cardiac mass. Okay, GU, one of my favorite things. So UTI, very, very common, more common in females than males. So if you get a UTI in a male, you're really worried about something congenital. Also, if there's a pediatric hydro, not making urine, we're thinking about a couple of things. So it's important to know the embryology and common pathologies. So pyelonephritis, infections, hopefully we have the urinalysis, and usually they'll come to imaging if they've had multiple UTIs, trying to figure out, is there something congenital? Here we see asymmetric enhancement. Here the left kidney has some areas of hypoenhancement, the striated nephrogram. Some renal anomalies, one of my favorites, the horseshoe kidney. You can get ectopias, malrotations. Sometimes just an incidental finding. Reflux, especially in females with chronic UTIs, we do a cystogram, fill up the bladder, and does it go up? Yep. Then how dilated is it? And then is there an underlying problem with the ureter that is going to require a reimplantation to decrease the reflux? Because what we want to avoid is chronic infections and chronic scarring leading to chronic renal disease later in life. That's why we take this so seriously. Okay, some fun other anomalies, duplications, megaureters, you name it, anything that can go wrong can go wrong. You can look up the Weigert-Meyer rule with duplications. That's one of my favorite things. And VCG is great for diagnosing these. Posterior urethral valves, some in the young boys we worry about, where there's a functional obstruction. So thick-walled bladder, dilated ureters, and the renal collecting system. Renal cystic disease, so something called the multicystic dysplastic kidney. Basically, it's going to be non-functional. So if it's, we're hoping that the other kidney is working, because if both kidneys are out, that's not compatible with life. So that's all. And if you have one anomaly, look at the other side, look at the reproductive system. Renal GU anomalies often occur in concert. So this is one of the things, this is a bunch of cysts, and you might look at this and say, hey, it looks like hydro. It's going to be a huge difference, because if it's hydro, we relieve the obstruction, the hydro goes away, but it's a bunch of cysts that are not communicating. That is not going to get better, and basically this is a congenital thing. It will eventually involute. Tumors, Wilms, shows up either on ultrasound or CT as a solid mass. I'm always looking for Mets on these. Neuroblastoma, horrible disease, and was spread to be very, very aggressive. And you see, looking for calcification, sometimes is this a Wilms tumor or a neuroblastoma? Sometimes some indications or radiology signs like calcifications can help us narrow the differential. Pelvic tumors now, rhabdomyosarcomas and teratomas. Adrenal hemorrhage, especially in newborns with trauma or stress. NICU patients, or often we'll get the indication, rapid blood loss, looking for the source, and it will be a hemorrhage in the adrenal gland. You can see there's the kidney. This is the adrenal above it. Okay, some things for the male GU, of course, the testes, things like cryptorchidism, torsion, microlithiasis. Female GU, teratomas, and you can read the whole list here. Neuro, not my strong point, but we will go over some pearls here. So neonatal ultrasound for our preemies. These are very sick patients, lots of lines and tubes. We're not going to put them in the CT scanner. We don't want to get them the radiation, but we can do ultrasound through the soft spot in the skull, looking for hemorrhages, and then germinal matrix going to the ventricles, and we grade these 1 through 4. And then PVL, periventricular leukomalacia, a little bit later on with the watershed ischemia. You see these cystic changes in periventricular white matter. So a whole laundry list of developmental abnormalities that I'll show some of the examples here. Chiari, low-lying tonsils, holoprosencephaly. Again, if you have one anomaly, look elsewhere. Cystic malformations in the posterior fossa. And some gray and white matter abnormalities. And often these are picked up, sometimes for seizure checks, new seizure, looking for any abnormality. Same thing with malformations, the gain of vena Galen malformation, which can be treated with embolization. This patients often show up with CHF. Some other vascular injuries. These are always fun. The neurocutaneous syndromes, these make great multiple choice questions. NF, tuberous sclerosis, Sturge-Weber. So you can read the slides about NF, tuberous sclerosis, and looking at other organ systems, especially with tuberous sclerosis, and the kidneys get renal cysts, renal angiomyolipomas, and we have some great examples in our GU RadPath video for that. Those little tubers there. Sturge-Weber, and realize this is CT, this is MRI, so the bones are bright, but you see all these calcifications. Just see how well we see the calcifications on the CT as opposed to the MRI. Infections, of course, always worrisome in a newborn. And this is something we're looking for either on CT or if it's early enough, on ultrasound, looking for these calcifications with the torches infections. And then, of course, the complications like hydrocephalus. HIV, fortunately, don't see this as often as we did when I was a resident. Encephalitis will be best picked up with MRI. Again, you watch the intro to MRI video. Some more details about that. Herpes, always worry about it if you have disease in the temporal lobes. Meningitis, very scary diagnosis. Hopefully we have a positive lumbar puncture and we're looking for complications such as abscess. Okay, tumors. You could do a whole talk on this, but things I want to point out, it's important to know the location, infratentorial or supratentorial, as well as suprasellar, and then the age of the patient. MRI is going to be our workhorse, probably detected first on CT and then better characterization with MRI. So I'll let you read through these slides, pause it if you want to. So intraventricular tumor here, again from a red path, this would be a big INI. But you see the complication causing hydrocephalus there. The suprasellar tumors, differential for that, age is important. Okay, the eye. So cellulitis, infection in a small space that can rapidly spread and cause complications. So diagnosing where it is, how bad the swelling is there an abscess, how much mass effect is there? And then the big deal, is it pre or post septal? And are the sinuses involved? Tumors, of course, can be pretty rare, but one of the common ones, the retinoblastoma, again, this is CT, and you can see the calcification there. Again, CT is going to be much better for picking up the calcification. So some skull anomalies, so it can do some great 3D rendering to help the plastic surgeons get a great view of what's going on with the skull. The lacunar skull, the hammer-beaten silver appearance. Spine, so congenital dystrophisms, and then trauma. So congenital with the butterfly vertebrae resulting in scoliosis, dystrophisms. GI, my next favorite topic. So neck in our preemies, looking for that pneumatosis, bubble-like lucencies, looking for the complications like free air. Big time free air, and something you can see the lateral radiograph really helps us. Omphalocele, a lot of times we'll have the diagnosis from the prenatal ultrasound and distinguishing that gastroschisis from omphalocele. Other congenital anomalies, important to tell upper from lower. The age is very important. So first, a day of life with bilious vomiting, we're thinking of malrotation, duodenal atresia / stenosis, volvulus, annular pancreas, versus a lower GI obstruction, meconium ileus, Hirschsprung's meconium plug. And one of my favorite is a 1-month-old with non-bilious projectile vomiting. You're thinking hypertrophic pyloric stenosis. We'll use ultrasound to diagnose that. So some nice examples of these pathologies. Again, often associated with syndromes. Look at the feeding tube there. It's coiling up. Here, I talked about pyloric stenosis in the old days. My dad was a resident using fluoroscopy, the string sign, marked narrowing, the tube is thickened. Now these days we'll use ultrasound. The double bubble for duodenal atresia. Again, looking for other syndromes. Talked about annular pancreas. Malrotation, this is a surgical emergency. So normally, and the best way to diagnose this is with the upper GI. Patient drinks the contrast, it goes through, sometimes you put it through a tube. And contrast should go through the duodenum, should cross the midline ligamental trites. But if it doesn't, it all coils on the right side. You have just diagnosed malrotation. Give the pediatric surgeon a call before this gut becomes necrotic. And there's another nice example, the corkscrew duodenum surgical emergency. Okay, so some lower GI things, meconium ileus, soap bubble in the right lower quadrant. Again, we're looking for complications in making the diagnosis. Meconium plug, often associated with diabetes, preeclampsia, so hopefully you have that history, but get these big innies or filling defects, which will hope, and if you've ever cleared one of these, it's quite amazing. And then you see the response of the colon and the bowel getting less distended after. This is one of the most satisfying things to help diagnose and then treat. And baby feels a lot better, and pediatrician feels a lot better. Okay, Hirschsprungs, caused by a migrational anomaly, and there'll be a big difference in tone at a certain point in the colon. So small, 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 more normal caliber there, normal caliber there. It's important to diagnose it and then tell the surgeon where that transition is so they can do the biopsy and confirm the diagnosis. So again, here the normal rectum and finding that transition. Okay, some other GI pathologies we'll go over. So infection, long laundry list, obstruction, talked about the rule of threes. We go over this in the surgery module as well. Important to know how the film was taken, upright or supine. Appendicitis, so can often make the diagnosis with ultrasound, especially with a young, thin patient, looking for a thickened wall, looking for that fecalith in there. CT, of course, you'll see the fecalith, you'll see that fat stranding around it. Take them to surgery. Okay, intussusception, current jelly stool. Looking at ultrasound, if you can see it, that tube within the tube appearance, bullseye. Sometimes you can see the soft tissue defect on the KAB. Meckel's diverticulum causes GI bleeding, especially in kids. Can do CT, see a tube. It's not the appendix. The rule of twos for the Meckel's diverticulum. And the way to diagnose it is a nuclear medicine scan, the Meckel scan. And you see the hot spot with the picking up the gastric mucosa in that Meckel's diverticulum. You have your diagnosis. Duplication cysts, this can occur anywhere. Adenitis is a patient with right lower quadrant pain. The appendix is normal, but you see all these lymph nodes. In my experience, this is usually like a viral thing. Can clinically look just like an appendicitis, but the appendix is normal radiographically. You save the patient the surgery, and the patient will hopefully get better with some time. Foreign body, these were our intro slides. So kids will eat anything. So trying to decide, is it in the esophagus or trachea? A couple of tricks you can do for that. Really worry about these battery magnets that get ingested, can flip on itself within the small bowel and cause big time obstruction, big time necrosis. So we'll go a little bit, let's pause here for a little bit for some of the biliary pathologies. So again, newborn, jaundice, this is always high on the list. The differentials want to rule that out and do nuclear medicine, ultrasound, looking to see if that gallbladder is there or not. Choledochal cysts, I can diagnose that with ultrasound, MRI. Liver masses, always scaring the newborn. Age is very important, less than 5, hepatoblastoma. Multiple, of course, thinking Mets. And, putting it all together with the AFPs, AFP will be high with hepatoblastoma and HCC. Okay, we have our own module on pediatric trauma and abuse, so I will go faster through here, but we're looking for lung contusions, rib fractures, abdominal trauma, and then neuro complications. Again, we have a whole module on this, looking for rib fractures, especially those posterior ones, fractures at different ages, very suspicious, abdominal trauma, head trauma, subdural hematoma, spine trauma. Okay, so lines. So it depends on the patient's age, newborn versus older patient. And we'll see what we got here. So endotracheal tube. I'm going to go a little bit faster through here, interest of time, but pause it, read the slide. Tracheostomy tube. Our ECMO kids. Central line, like that to be an SVC. PIC. Coming from the periphery. Chest tube. For the newborns, the umbilical artery and umbilical vein catheters. Some tricks about how to tell those apart. Our NG tube, again, we want to come below the diaphragm, a little bit to the left of midline. As opposed to a Dobhoff feeding tube, see how radiopaque it is here, as opposed to non-radiopaque at the tip. So these ones we like to be in the duodenum, ideally. Okay, some Hartmand pearls. Now that was fast, but we talked a little bit about small bowel obstruction. This is a great differential, especially for peds. AIM, adhesions, appendicitis, we saw that with ultrasound and CT. Inguinal hernia in the susception, we saw that current jelly stool. We saw that in ultrasound and plain film. Malrotation, we saw that with the upper GI. And Meckel's, we saw that with the nuclear medicine scan. So 1 day old with bilious non-projectile vomiting. We are thinking malrotation, duodenal atresia, annular pancreas. So this is the big time surgical emergency. We diagnose this with upper GI. The contrast does not pass. It goes in the duodenum, but does not go to the ligament detritus. All the bowel stays to the right of midline. As opposed to a 1 month old projectile non-bilious vomiting, this is a hypertrophic pyloric stenosis, and we will diagnose it with ultrasound, looking for that pyloric thickening and narrowing of the channel. And I will leave it to Davin for some cases.
All right, thank you, Dr. Hartman. That was a lot of information, but a lot of crucial stuff for the pediatrician to understand, especially those who are going through their courtship. A lot of high yield buzzwords that you'll see on the shelf when you're getting pimped. A lot of those imaging things are crucial in pediatrics, and knowing what tests to order and what you're looking for. And for those interns who are going into pediatrics, this is stuff that is going to get you so far. I absolutely loved looking at pediatric imaging on my rotation and was able to impress some attendings with the knowledge that I had. from the ACR building blocks. So we're just going to run through a single case, something that I think is super important to understand in the context of pediatrics and something that a lot of pediatricians will see. So you've got a 9-year-old female brought to the clinic complaining of trouble breathing and wheezing, obviously suspicious of asthma here. If it's asthma, they're wheezing, but not everything that wheezes is asthma. Kind of what I've been told. What test should we order for the patient? Chest radiograph. Nice. What should we do before the patient gets imaging? It's kind of a question that a lot of MBMEs or shelves will ask you. You got to treat them. So here's your radiograph. What are we looking at here? We're looking at a pneumomediastinum, some bronchial thickening, focal atelectasis, and hyperinflation. So this isn't specific to asthma, but obviously clinically correlating it with the wheezing, most likely asthma. And if you treat it, the wheezing goes away, definitely asthma. You can also get a CT, it's more sensitive to changes in asthma. And the reason we don't get CTs as often is because it exposes the children to additional radiation and it also costs more. So that's it. Super straightforward with at least the case, but a ton of high yield stuff in there. Definitely worth your time. I know it's a bit of a longer video, but this will get you so far on your clerkship and in your intern year and into your pediatric residency. So thank you for your time.